Good day everyone. Today we will discuss about serology and molecular detection of viral infections. Before we begin, let's first define viruses. Viruses are submicroscopic pathogen whose size is measured in nanometers. Viral infections pose a significant threat to the human body, necessitating a robust defense system to thwart their invasion. The immune system, specifically innate immunity, acts as the initial line of defense against viral pathogens. Innate immunity, the first line of defense. We have natural occurring barriers, which consist the skin and mucous membranes that serve as physical barriers preventing viral entry. Next, we have recognition of viral presence. Cells of the innate immune system identifies pathogen-associated molecular patterns or pumps on virus-infected cells. Non-specific defenses against viruses. We have type 1 interferons, IFN alpha and IFN beta, and natural killer cells plays crucial roles. IFN production triggered by toll-like receptors or TLR recognizing viral RNA. IFNs inhibit viral replication and enhance natural killer cell activity. Natural killer cell, on the other hand, releases cytotoxic proteins, causing infected cell death and viral release. Next, we have specific humoral defenses. First, we have the activation of specific immune responses. Specific humoral and cell-mediated defenses are activated when innate defenses are insufficient. Next, we have the production of virus-specific antibodies. B cells and plasma cells produce antibodies to attack free virus particles. Next, we have antibody attack on free virus particles. Neutralization process prevents viral attachment and penetration into host cells. We have secretory IgA antibodies neutralize viruses in mucosal surfaces. IgM and IgG antibodies inhibits infection dissemination. Antibody functions. First, opsonizing activity promotes phagocytosis. 2. Antibody-dependent cell-mediated cytotoxicity or ADCC. Next, we have complement activation or the opsonization via C3v and lysis. Next, we have IgM antibodies agglutinate viral particles. And lastly, we have cell-mediated defenses. First is the activation when intracellular viruses are present. Cell-mediated immunity becomes crucial for eliminating intracellular viruses. Involvement of Th1 cells and CTL. Th1 cells produce interferon gamma, inducing an antiviral state. Interleukin 2 assists in developing effect CTLs. Third, we have recognition and attack mechanism. T cells receptor or TCR on CTL recognizes viral antigen MHC class I complex, CD8 co-receptor and co-stimulator molecules such as B7 and CD28 provide signals. And last, we have CTL response mechanism. CTL release perforin and granzymes inducing apoptosis in infected cells, interruption of viral replication cycle, and release of infections virans. CTL response involves significant cell divisions, producing a formidable defense.
Now let's go on to the viral escape mechanisms. So how can the virus escape the host's defense mechanism? First is through frequent genetic mutations. New viral antigens are produced as a result, which the immune system is unable to recognize. As a result of this, the infection manages to get out. The ongoing evolution of the influenza virus is one example of this, leading to the appearance of new strains and the yearly need for the production of new vaccinations. Second is through the action of innate immune system components such as interferons, complement proteins, or lysosomal enzymes in the phagocytic cells. An example of this is that the hepatitis C virus can block interferon-mediated degradation of viral RNA, and the herpes simplex virus produces protein that binds to the complement component C3b, resulting in inhibition of the complement pathways. Third is by suppressing the adaptive immune system. Some viruses reduce the expression of class 1 MHC molecules on the surface of virus-infected cells, making them unrecognizable. An example of these are the cytomegalovirus and HIV. And lastly, through remaining in latent state by integrating their nucleic acid into the genome of the infected host cells. A virus that does this are cytomegalovirus, varicella zoster virus, and HIV. These viruses replicate only if the host is exposed to other infectious agents or if the immune defense of host declines. These latent viruses can remain silent for years because they are hidden from the immune system. Through these four evasion mechanisms, the viruses can escape the host's defense mechanism and can cause mild to life-threatening diseases.
As our knowledge of viruses has increased, so has the development of laboratory assays to detect viral infections. Serological and molecular tests can be easily and rapidly performed by the clinical laboratory. Therefore, they play an essential role in helping the physicians establish a presumptive diagnosis so that treatment can be initiated promptly. Serological tests are also important in monitoring the course of infection, detecting past infections, and assessing the immune system status, whereas molecular tests have enhanced our ability to detect active infections and are essential in guiding antiviral therapy. In general, the presence of virus-specific IgM antibodies in patient serum indicates a current or recent viral infection, whereas IgG antibodies to a virus signify either a current or past infections, and in many cases, immunity. Virus-specific IgM antibody in the newborn serum indicates a congenital infection because IgM antibody is actively made during fetal life. In contrast, IgG antibodies in the pre-infant serum are mainly maternal antibodies that have crossed the placenta. Current infections in the adult or newborn may also be detected by immunoassays for viral antigens in serum or other clinical samples, or by the presence of viral nucleic acids that can be detected by molecular methods.
On the following slides, we will talk about the hepatitis viruses and their associated serological and molecular markers. So first, let's talk about hepatitis A. It is under the type and family of RNA picornaviridae, and its transmission are fecal oral route and blood transfusion, which is very rare. And the hepatitis A has no progression to chronic state, but it has complications such as low risk of fulminant liver disease. It has several serological and molecular markers such as IgM anti-hepatitis A, total anti-hepatitis A, and lastly, hepatitis A RNA. It has clinical significance such as acute hepatitis A, immunity to hepatitis A, and detection of hepatitis A in clinical food and water samples. On the other hand, let's talk about hepatitis B. It is under the type and family of DNA Hepataviridae. It is transmitted through parenteral, sexual, perinatal transmission, and it has progression to chronic state. Also, it has complications since 10% to 90% of cases may develop to chronic hepatitis depending on age, which increased risk for liver cirrhosis and hepatocellular carcinoma. It has several serological and molecular markers such as hepatitis B surface antigen, hepatitis B E antigen, IgM anti-hepatitis B core antigen, total anti-hepatitis B core antigen, anti-hepatitis B E antigen, anti-hepatitis B surface antigen, and lastly, hepatitis B DNA. It has clinical significance as well, such as active hepatitis B infection, active hepatitis B with high degree of infectivity, current or recurrent acute hepatitis B, current or past hepatitis B, recovery from hepatitis B, immunity to hepatitis B, and lastly, acute, atypical, or occult hepatitis B viral load may be used to monitor the effectiveness of therapy. On the third slide, we will talk about hepatitis C virus, which is under the type and family of RNA flaviviridae. It is transmitted through parenteral, sexual, perinatal transmission, and it also has progression to chronic state. It has complications since 85% develop to chronic infection with increased risk of cirrhosis, hepatocellular carcinoma, or autoimmune manifestations. Serological and molecular markers includes anti-hepatitis C and hepatitis C RNA. It has several clinical significance such as current or past hepatitis C infection, current hepatitis C infection, which viral load may be used to monitor the effectiveness of therapy, and it is also used to determine the hepatitis C genotype. On the following slide, we will talk about hepatitis D, which is under the type and family of RNA genus Delta virus. And it is transmitted mostly parenteral but also sexual and perinatal, and it could be also in hepatitis D infection acquired. And also, it progressed to chronic state since it also has complications such as increased risk of developing fulminant hepatitis, cirrhosis, or hepatocellular carcinoma. It also has different serological and molecular markers such as IgM anti-hepatitis D, IgG anti-hepatitis D, and hepatitis D RNA. And lastly, it also has clinical significance such as acute or chronic hepatitis D, recovery from hepatitis D or chronic hepatitis D, and lastly, active hepatitis D infection, which viral load may be used to monitor the effectiveness of therapy. On the fifth and last slide regarding hepatitis viruses is hepatitis E, which is under the type and family of RNA hepaviridae. It is transmitted through fecal oral route or blood transfusion. And it also progresses in chronic state, also in immunocompromised individuals. It has complications such as fulminant liver failure in pregnant women. And regarding to its serological and molecular markers, it includes IgM anti-hepatitis E, IgG anti-hepatitis E, and lastly, hepatitis E RNA. On the other hand, on its clinical significance, current hepatitis E infection, current or past hepatitis E infection, and lastly, current hepatitis E infection.
The herpes virus infections are large and complex DNA viruses that are surrounded by protein capsid, an amorphous tegument, and an outer envelope. These viruses are all capable of establishing a latent infection with lifelong persistence in the host. The herpes viridae family includes 8 viruses that can cause disease in humans. The herpes simplex virus or HSV1 and HSV2, VZV, EBV, ZMB, and the human herpes viruses HHV6, HHV7, and HHV8, the latter of which has been associated with Kaposi sarcoma. This section represents the clinical manifestation and laboratory diagnosis of some of these viruses.
So let's move forward to the Epstein-Barr virus. So the EBV causes a wide spectrum of diseases including infectious mononucleosis, proliferative disorders, and several malignancies. So, yung EBV infections most commonly result from intimate contact with salivary secretions from uninfected individuals. And transmission of the virus can occur by means such as blood transfusion, bone marrow and solid organ transplants, sexual contact, and prenatal exposures. Though yung routes na to appear to be much less frequent. And in developing nations of the world and lower socioeconomic groups living under poor sanitation, yung EBV infections usually occur during early childhood, whereas sa industrialized nations with higher hygiene standards, yung infections are typically delayed until adolescence or adulthood. However, by adulthood, more than 95% ng individuals have been infected as evidenced by the presence of the EBV antibodies in their serum. And then the initial infection with EBV is believed to occur sa oropharynx where yung virus primarily infects epithelial cells and B lymphocytes. So here is the EBV infection cycle. So yung EBV binds sa beta-1 integrins on the surface of the epithelial cells which take up the virus by endocytosis, and inside the oropharyngeal epithelial cells, yung EBV pumapasok siya sa lytic cycle which is characterized by viral replication, lysis of host cells, and release ng infectious virions until yung acute infection is resolved. Yung virions na to, nagsispread siya to adjacent structures including the salivary glands and tonsils. Doon, yung EBV infection or yung EBV, in-infect niya yung B lymphocytes which spread the virus throughout the lymphoreticular system. And then, yung EBV, nag-enter siya sa B cells by binding to surface CD21, which is also a receptor for C3D component of complement. Then, yung virus-infected B cells become polyclonal activated, proliferating and secreting a number of antibodies, including yung EBV-specific antibodies, heterophile antibodies, and autoantibodies such as cold agglutinins, rheumatoid factor, and anti-nuclear antibodies. Sa healthy individuals, yung process na to is kept in check by the immune response ng NK cells and specific na cytotoxic lymphocytes. However, yung EBV can persist in the body indefinitely in a small percentage ng memory B cells where it establishes a latent infection. And sa latent state, yung EBV nucleic acid exists as episomal DNA. So, episomal DNA, it is either existing sa cytoplasm or naka-attach sa chromosome. Then, in these cases, active viral replication does not occur, and sa periodic reactivation results in re-entry of the virus into the lytic cycle, with viral shedding into the saliva and genital secretions, even sa healthy and asymptomatic individuals. So, several antigens have been identified in EBV-infected cells that are associated with different phases of the viral infection. Antibodies to these antigens have become an important diagnostic tool. Antigens produced during the initial stages of the viral replication and the lytic cycle are known as the early antigens, or dito yung sa early acute phase. These antigens can be further classified into two based on their location within the cell. So we have the EAD or the early antigen diffuse, which has a diffuse distribution sa nucleus and cytoplasm, whereas yung EAR naman, or the early antigen restricted, which is restricted lang siya sa cytoplasm. So the late antigens ng EBV are those that appear during the period of the lytic cycle following the viral DNA synthesis. So these include the viral capsid antigens or the VCAs and the protein capsid and the membrane antigens in the viral envelope. Then yung antigens naman na nag-a-appear sa latent phase include the EBV nuclear antigen or the EBNA proteins, EBNA1, EBNA2, EBNA3 or yung 3A, EBNA4 or yung 3B, EBNA5 or yung LP, and EBNA6 or yung 3C. And yung latent membrane proteins include the LMP1, LMP2A, and LMP2B. So, for EBV clinical manifestation, the clinical manifestations of EBV vary with the host's age and immune status. Infection in infants and young children are generally asymptomatic or mild, whereas primary infections in healthy adolescents or adults commonly results in infectious mononucleosis. More than half of patients with infectious mononucleosis present with 3 classic symptoms. We have fever, lymphadenopathy, and sore throat. Symptoms usually last for 2 to 4 weeks, but yung fatigue, myalgias, and need for sleep can persist for months. Treatment is mainly directed at alleviating symptoms, although associated as symptoms are essential in diagnosing infectious mononucleosis. They can also be caused by many other infectious agents, so yung laboratory testing plays an important role in differentiating IM from other infections. Then we have the laboratory findings. So characteristic laboratory findings in patients with IM include an absolute lymphocytosis of greater than 50% of the total leukocytes and at least 20% atypical lymphocytes. The atypical lymphocytes are predominantly activated cytotoxic T cells that are responding to the viral infection. So yung serologic findings include the presence of a heterophile antibody and antibodies to certain EBV antigens. By definition, yung heterophile antibodies are antibodies na capable of reacting with similar antigens from two or more unrelated species. The heterophile antibodies associated with IM are IgM antibodies produced as a result ng polyclonal B cell activation and capable sila of reacting with horse RBCs, sheep RBCs, and yung bovine RBCs. Yung antibodies na to are produced by 40% of patients with IM during the first week of clinical illness and by 80 to 90% of patients by the third week. They disappear in most patients by 3 months after the onset of symptoms, but pwede pa rin silang ma-detect in some patients for 1 to 2 years. Because yung heterophile antibody is present sa most patients during the acute phase of illness, testing for this antibody has been typically performed to screen for IM in patients who present with symptoms of the disease. Then for many years, the heterophile antibody of IM was detected by a rapid slide agglutination method called the monospot. So sa monospot, yung serum premixed with guinea pig kidney antigen was still capable of agglutinating sa horse RBCs, whereas yung serum premixed naman with beef erythrocyte antigen could not agglutinate horse RBCs kasi yung heterophile antibody ay na-absorb during the first step. So yung test was used to distinguish the heterophile antibody of IM from heterophile antibodies produced in other diseases which had different reactivity. So yung antibody could be titered by incubating serial dilutions of the patient's serum with sheep RBC sa Paul Bunnell test. So, but today yung methods na to have been replaced by more sensitive rapid agglutination tests or immunochromatographic assays using purified bovine RBC extract as the antigen. So let's move forward to the EBV markers. IgM antibody to the VCA is the most useful marker for acute IM because it usually appears at the onset of clinical symptoms and disappears by 3 months. IgG anti-VCA is also present at the onset of IM but persists for life and can thus indicate a past infection. So antibodies to EAD ay makikita rin during acute IM whereas anti-EBNA nag-appear siya during convalescence. Thus, the acute primary infection is typically indicated by the presence ng IgM anti-VCA and anti-EAD as well as the absence ng anti-EBNA. Then we have a summary ng serological responses during acute convalescent and post-IM. Ito yung table na yun. Some individuals develop chronic active EBV infection with severe, life-threatening IM-associated symptoms that persist or recur for more than 6 months after the acute illness. In addition, EBV can sometimes integrate its DNA into the genome of the cells it infects and transform them into cancer cells. As a result, EBV has been associated with several malignancies, both hematologic such as Burkitt's lymphoma and Hodgkin's disease, and non-hematologic such as nasopharyngeal carcinoma and gastric carcinoma. EBV can also cause lymphoproliferative disorders in immunocompromised patients, including CNS lymphomas in patients with AIDS, X-linked lymphoproliferative disease in males with a rare genetic mutation, and post-transplant lymphoproliferative disorders or PTLD in patients who have received the hematopoietic stem cell or solid organ transplants. These disorders result from the inability ng immunosuppressed patients na makontrol yung primary EBV infection, which leads to massive polyclonal expansion ng EBV-infected B cells and life-threatening illness with a high rate of mortality. And EBV-associated malignancies can be diagnosed with the help of serology tests for EBV antibodies and molecular methods to detect yung EBV DNA sa blood and tissue samples. Then, molecular tests may be more reliable than serology in immunocompromised patients who may not demonstrate a good humoral response. Quantitative real-time PCR is useful in monitoring viral load in transplant patients, and a high or steadily increasing EBV viral load indicates the need to decrease yung immunosuppressive treatment and administer antiviral therapy. Detection of EBERs or EBV-encoded RNA transcripts by in situ hybridization is the method of choice for detecting EBV in tumor tissues.
Cytomegalovirus. CMV is a ubiquitous virus with worldwide distribution. The prevalence of CMV ranges from 40% to 100% depending on the population and increases with age. Transmission of the virus can occur in a variety of ways, such as spread through close prolonged contact with infectious body secretions, intimate sexual contact, blood transfusions, solid organ transplants, and perinatal exposure from infected mother to infant. It can be isolated in body fluids such as saliva, urine, stool, vaginal and cervical secretions, semen, breast milk, and blood. Primary or initial infections in healthy individuals are usually asymptomatic, while some people experience a self-limiting, heterophile, antibody-negative IM-like illness with fever, myalgias, and fatigue. A small number of immunocompetent individuals who have other underlying disorders may develop severe CMV disease, which most commonly involves the gastrointestinal tract, CNS, and hematologic abnormalities. Clinical consequences of CMV infection are much more serious in the immunocompromised host, most notably organ transplant recipients and patients with HIV or AIDS. CMV is the most important infectious agent associated with organ transplantation. CMV infection of a previously unexposed recipient is associated with increased risk for allograft failure or graft versus host disease or GVHD. Although combination antiretroviral therapy has reduced the incidence of CMV-related illness in patients with HIV infection, CMV remains a major opportunistic pathogen in patients with low CD4 T-cell counts. CMV is also the most common cause of congenital infections, occurring in 0.3% to 2.3% of all neonates. Transmission of the virus may occur through the placenta, by passage of the infant, through an infected birth canal, or by postnatal contact with breast milk or other maternal secretions. Symptomatic infants present with a multitude of symptoms that reflect platelet dysfunction and CNS involvement. And the 10% of infants who are asymptomatic at birth progressively develop sensorineural hearing loss. For serology testing, serology is the most beneficial in determining a past exposure to the virus. Identify CMV-positive donors so that transplantation of their organs into CMV-negative recipients can be avoided. If a CMV infection has been established in a transplant patient, immunosuppressive treatment should be reduced to the lowest dose possible. In addition, a variety of antiviral drugs are currently used to treat CMV infection and in some instances be given prophylactically. Laboratory methods, viral culture identification of CMV antigens, molecular tests for CMV DNA are necessary to detect a current CMV infection in individuals who are immunocompromised or in neonates suspected of being congenitally infected with CMV. While CMV antigenemia assay is a widely used method for direct identification of CMV, uses immunocytochemical or immunofluorescent staining to detect the CMV lower matrix protein, PP65, in infected leukocyte from peripheral blood or cerebrospinal fluid. Although the antigenemia assay and shell vial culture methods are sensitive, specific, and rapid, they are labor-intensive and require personnel with expertise in performing and interpreting this test. For these reasons, they are progressively being replaced with molecular methods that detect CMV DNA or mRNA. A real-time PCR is the most widely used molecular method because it is sensitive, simple to perform, and can provide quantitative results. PCR amplification of CMV DNA has been extremely useful for detecting CMV infections in HIV-infected hosts and establishing the diagnosis of CMV infection in transplant recipients. Identification of CMV or CMV DNA in amniotic fluid after the 20th week of gestation is considered the gold standard for confirmation of fetal infection. Neonatal infection is established by detecting CMV or CMV DNA in the urine of the infant during the first 10 days of life. Quantitative PCR, which detects the CMV COMPI number in the peripheral blood, is used to monitor the effectiveness of antiviral treatment in immunocompromised hosts and to identify patients at risk for developing disseminated CMV disease. Although serology tests for CMV have been commercially available for many years, clinical utility is limited. The serology methods performed most commonly are semi or fully automated EIAs that employ microtiter plates or microparticle system. On the other hand, serological methods that distinguish CMV antibody avidity appear to be more useful in distinguishing a past exposure from a current primary infection. Low avidity IgG antibodies indicate a recent infection, while high avidity IgG antibodies reflect a past exposure. The presence of both IgM and low avidity IgG antibodies can help identify pregnant women who have contracted a primary CMV infection. Direct methods of detecting CMV infection are essential. For varicella zoster virus, VCV is the cause of two distinct diseases, which are varicella, or more commonly known as chickenpox, and herpes zoster, also known as shingles. It is transmitted primarily by inhalation of infected respiratory secretions or aerosols from skin lesions associated with the infection, and transplacental transmission to the fetus may also occur. Primary infection with VCV results in varicella, a highly contagious illness characterized by a blister-like rash with intense itching and fever. Majority of varicella cases have occurred during childhood. In a typical infection, vesicular lesions first appear on the face and trunk and then spread to the other areas of the body. The illness is usually mild and self-limiting in healthy children. Infections in adults, neonates, or pregnant women tend to be more severe, with a larger number of lesions and a greater chance of developing other complications such as pneumonia. Varicella infection, we can classify them in pregnant women and immunocompromised patients. First, in pregnant women, it may cause premature labor or congenital malformations if the infection is acquired during the first trimester of pregnancy, or may cause severe neonatal infection if transmission of the virus occurs around the time of delivery. For immunocompromised patients, scrapings from vesicular lesion with monoclonal antibodies like to result in disseminated disease with intensive skin rash, neurological conditions, example, encephalitis, and other complications including pneumonia, hepatitis, and nephritis. VCV is thought to to travel from the skin lesions and the blood to sensory neurons, where it deposits its DNA and establishes a lifelong latent state in the dorsal root, autonomic, and cranial ganglia. Reactivation of VCB with active viral replication occurs in 15% to 30% of persons with a history of varicella infection. During reactivation, the virus moves down the sensory nerve to the dermatome supplied by the nerve, resulting in eruption of a painful vesicular rash known as herpes zoster or shingles in the affected area. Life-threatening complications such as herpes ophthalmicus that lead to blindness, pneumonia, and visceral involvement are more common in immunosuppressed persons. In 2005, vaccine was licensed for use in healthy children that combines the varicella vaccine with that for measles, mumps, and rubella. In addition, a single-agent VCV vaccine was licensed in 2006 for prevention of herpes zoster in persons aged 60 or older, presumably by boosting T-cell immunity to the virus. For laboratory testing, it is the most important in the diagnosis of atypical cases such as those in which the rash is absent or delayed, and in immunocompromised patients with disseminated disease. Definitive diagnosis is based on identifying VSV or one of its products in skin lesions, vesicular fluids, or tissue. Older methods of identification involve cell culture and microscopy, but these have significant disadvantages. Culture of the virus and observation of characteristic CPE can be performed in a number of cell lines, but it is time consuming, usually 4 days to 2 weeks, and may not yield productive results if clinical specimens do not contain sufficient amounts of the infectious virus. In terms of microscopy, microscopic detection of multinucleated giant cells called sunk cells in stain smear made from material from the vesicle allowed for rapid identification of the virus, but this procedure could not distinguish between infection VCV or HSV. Today, real-time PCR for VSV DNA is laboratory method of choice for diagnosing varicella zoster infection because it is highly accurate, sensitive, and rapid. Quantitative real-time PCR is also useful in monitoring the response of immunocompromised patients to antiviral drugs. PCR can be performed on a variety of samples including vesicular fluid or scabs, skin swabs, throat swabs, cerebrospinal fluid, blood, saliva, and tissues from biopsies or autopsies. Fluorescent antibody to membrane antigen or FAMA is a fluorescent test, most sensitive and reliable method of detecting VCV antibody. It detects antibody to the envelope glycoproteins of the virus, although FAMA is considered to be the reference method for VCV antibody. It requires live virus-infected cells and is not suitable for large-scale routine testing. The most commonly used method to detect VCV antibodies in the clinical laboratory is the ELISA, or enzyme-linked immunosorbent assay. Because it is automated, it provides objective results and does not require viral culture. Although older ELISA methods that employ a whole antigen extract are less sensitive than FAMA, a newer ELISA that detects antibody to a highly purified VCB envelope glycoprotein has been shown to have a high level of sensitivity.
Next, we will be discussing other viral infections. First from the list is rubella. It is a single-stranded envelope RNA virus of the genus Rubivirus, belonging to the family Togaviridae. It is transmitted through respiratory droplets or transplacental infection of the fetus during pregnancy. It is a German measles and it is the mainly disease for children. It also produces a characteristic erythematous maculopapular rash which appears first on the face, then spreads to the trunk and extremities and usually resolves in 3 to 5 days. It is commonly 50% are asymptomatic. During pregnancy, it may have severe consequences including miscarriage, stillbirth, or congenital rubella syndrome. Scientists develop a vaccine consisting of live attenuated rubella virus. So here are the laboratory diagnoses of rubella infection that can be accomplished through culture of the virus, demonstration of viral RNA, detection of virus-specific antibodies, and the most widely used molecular method, which is the RT-PCR, and the serology test, which are the most common means of confirming the rubella diagnosis. By the presence of rubella-specific IgM antibodies, only about 50% of patients are positive for IgM antibodies on the day that the rash appears. The laboratory diagnosis of congenital rubella infection begins with serological evaluation of the mother's antibodies. Serology tests are also used to screen for immunity to rubella in populations such as the pregnant women or healthcare workers. The second from the list is rubeola. It is a single-stranded RNA virus belonging to the genus Morbillivirus in the Paramyxoviridae family. It is a highly contagious infection that is spread by direct contact with aerosolized droplets from the respiratory secretions of infected individuals. It is usually disseminated through the blood to multiple sites in the body, such as the skin, lymph nodes, and liver. It is considered also as measles. Complex spots appear on the mucous membranes. It appears about 14 days after exposure to the virus. It is a systematic or systemic infection that can result in complications including diarrhea, otitis media, croup, bronchitis, pneumonia, and encephalitis. It is also considered as subacute sclerosing panencephalitis. Newer vaccine is used in the routine immunization schedule of infants and children. It is recommended administration of the vaccine is in 2 doses. The diagnosis of measles has typically been based on clinical presentation of the patient. Serological testing provides the most practical and reliable means of confirming a measles diagnosis. It is also indicated by the presence of rubella-specific IgM antibodies or by a fourfold rise in the rubeola-specific IgG antibody titer. A variety of methods have been developed to detect IgG rubella antibodies, such as the ELISA, and the presence of rubella-specific IgG antibodies indicates immunity to measles. Molecular methods to detect rubeola RNA can be used in cases in which serological tests are inconclusive or inconsistent. The third from the list is the mumps virus. It is also similar to rubeola, which is a single-stranded RNA virus that belongs to the Paramyxoviridae family, which the genus is Rubula-virus. The average incubation period is 14 to 18 days. The inflammation of the parotid glands or parotitis is the most common clinical manifestation of mumps, occurring in 30% to 40% of cases. Mumps infection in pregnant women results in increased risk for fetal death. The vaccine is most commonly combined with vaccines for rubella and mumps, or the MMR, or is used in combination with the rubella, mumps, and varicella vaccine, or the MMRV. The diagnosis of mumps is usually made on the basis of clinical symptoms, especially parotitis, and does not require laboratory confirmation. Culture is considered to be the gold standard for laboratory confirmation of acute infection. Preferred specimens are a buccal swab or saliva from the buccal cavity collected within 3 to 5 days of symptom onset. The specimen can then be used to inoculate cell lines such as primary monkey kidney cells and varus cells, which are grown in shell vial cultures and stained with fluorescent labeled monoclonal antibodies to identify mumps antigens. Standard and real-time RT-PCR methods have been developed to detect mumps virus RNA in specimens collected. RT-PCR is recommended as the primary diagnostic test for mumps because it is more sensitive than serology. ELISA technique is the most commonly used method to detect mumps antibodies because it is sensitive, specific, cost-effective, and readily performed by the routine clinical laboratory. Next from the list is human T-cell lymphotropic viruses. HTLV-1 and HTLV-2 are closely related in retroviruses. Both viruses have three structural genes, the GAG, which codes for viral core proteins, POL, which codes for viral enzymes, and ENV, which encodes proteins in the viral envelope, as well as the region called PX, which encodes several regulatory proteins including the TAX. The function is to transcribe the viral RNA into DNA. HTLV-1 and HTLV-2 exist predominantly in the proviral state and are spread directly to uninfected cells through a viral synapse. The human T-cell lymphotropic viruses preferentially infect CD4 plus T lymphocytes but can also infect CD8 plus T cells, dendritic cells, and macrophages. It can also be transmitted by three major routes: the blood-borne, which is mainly through transfusions containing cellular components or through intravenous drug abuse; sexual contact, most commonly from men to women; and mother to child, mainly through breastfeeding. HTLV-1 is the cause of two diseases: the adult T-cell leukemia or lymphoma (ATL) and HTLV-associated myelopathy tropical spastic paraparesis or HAM or ISP. ATL can be classified into four different subtypes based on clinical manifestations: the acute, lymphomatous, chronic, and smoldering. HTLV-1 has also been associated with a variety of autoimmune and inflammatory disorders including uveitis, infective dermatitis, myositis, and arthropathy. Serological testing plays an important role in detecting HTLV-1 and HTLV-2 infections because culture of the viruses requires sophisticated techniques that cannot be performed in routine clinical laboratories. The tests most commonly used for screening are ELISA or CLIA methods that incorporate recombinant antigens or synthetic peptides from both HTLV-1 and HTLV-2. Particle agglutination tests have also been developed. Any samples producing a reactive result in the initial screen is retested by the same method and subsequently tested by a confirmatory method to reduce the incidence of false positive results and to distinguish between HTLV-1 and HTLV-2 infections. Commercially available Western blot assays are most commonly used for confirmation. PCR methods can also be used to monitor the proviral load in patients with HTLV associated diseases during therapy and to demonstrate the presence of the virus in cells from patients who are suspected of having HTLV associated diseases.